you guys did a little bit more acid-base balance in NP2, which is interesting because that's more like an NP4 maybe topic, but you guys got the introduction to it, so you'll come back to that again in NP4 and talk about like your compensation with it when it comes to acid-base balance. But you got the general idea, you're understanding we're trying to maintain homeostasis here. And with this one, we're going to talk about really just more of the water and the fluid volume balance and dehydration, not so much on the acid-base balance part of things. We talked a lot about that more with RSV than we are in this actual part of the presentation. But remember this one? I got this little weird thing here. I don't know why this is here. Okay. So I like this picture still. It comes from NP1. I pulled it over from that presentation. Just as your reminder where our fluid is. And when we're talking about dehydration, when it comes to hypo, hyper, and isotonic dehydration, we're talking about extracellular fluid, right? So what's in the tissues, but primarily what's in the plasma, what's in our blood, what's in our veins, what's going on there, right? So you know we have fluid in the cells, we have fluid outside of the cells, and then two areas outside that cell. So why is maintaining fluid and electrolyte balance particularly important in kids, in pediatrics? You may have an idea? Because they, what?
It's harder for them to regulate their fluid.
It's harder for them to regulate their fluid and electrolyte balance, yeah. Any other reasons? Hard to regulate, so yes, kidneys have a hard time with that balance. And in infants, they really don't do much with balancing. It's more about the losses too. They lose it a lot quicker. They have, the younger you are, the more surface area you have, and higher potential for those insensible type losses. So, and kids are not just smaller adults. Their proportions are a lot different. A toddler's head is like the same size as like their torso. I like it when they're walking. Babies are cute, but I like when they're causing trouble. When they're mobile. They can get up and get out. Because their personality starts coming out. And they enter a room, belly first, right? Can you imagine us as an adult? Like those videos of adults acting like their cat, or the adults acting like their toddler. They storm into the room like if adults acted like a 2-year-old. Some of them do. But we don't want to think of them like they're small adults. And I've heard some residents on the adult side say that one in my day a couple years ago. Say, oh, they're just small adults. I'm like, no, they're not. Total body water varies. So this little graph shows you about 80% total, 80 to 90 in extremely preterm infants is water. 75% in newborns. So yes, little Walker Woodard has about 75% total body water. 45% in late adolescence. All right, so you make more stuff and have less water. Imbalances occur more rapidly in infants. So when they have a loss, they go downhill quick, right? This is why some people don't like pediatrics. Then they get sick quick. So here's just another picture just kind of showing you of that 75%. We have about half of it in extracellular fluid, right? And 30% in the cell. So you think about where we lose that water when they get sick, right? GI losses, they lose a lot of that. So just kind of showing, this isn't something to memorize, just kind of giving you an idea of how that's distributed. Look at her face. That's what I'm talking about, that Billy First little attitude. Kidneys are immature until about 2 years old. So we're talking about the ability of the kidneys to regulate fluid and electrolyte balance. So they're unable to conserve water and electrolytes or fully assist in that acid-base balance. So it happens quick. It gets sick quicker. So yes, that body surface area promotes fluid loss, those insensible losses like through your skin and breathing, that stuff we can't measure. So under normal circumstances, the amount of water ingested should be about what comes out in a 24-hour period. So, you know, intake and output, what do they drink? Easier if you're got bottle-fed infant. For breastfed infants, we usually just measure that in time. How many minutes they were breastfeeding. We'll give the mom a little record sheet. They can write how long. That doesn't equate to a certain volume. It's really an estimate, and it's all, every baby's different on how they feed. They take longer to feed when they're younger. They get a little bit more efficient as they get older. Breast milk changes. So we just track that. Are they feeding normally, and are they latching, and do they seem satiated when they're done? But on the output side of things, we'll take their diaper and we can weigh their diaper and determine how much comes out. And we subtract the weight of a dry diaper. So the osmolality of a gram on that gram scale of urine is about equal to a milliliter of water. So it kind of equals out. So water in food and from oxidation approximates the amount lost in feces through evaporation. So whatever they eat, you know, because there's fluid you can't measure and let them PL unless it's like pure liquid like in an infant. But solid food, it equals about. So that's why that kind of balances out. We don't measure that insensible loss because it kind of balances out with what we eat. And then maintenance water requirement is the volume of water needed to replace normal fluid losses. So I bring that up because you hear about what their maintenance IV fluids are and what their replacement IV fluids are. You might have heard this in the adults. I live in the pediatric world. It's a big deal for us. Maybe you talk about it a little bit in the adult world, or they just order IV fluids and maybe you don't even realize that's what they're doing, right? But we have, what's their maintenance? Or we might talk about like, hey, let's start them on 1.5 maintenance. You might hear that with an admission on a new child if you're inpatient pediatrics. That means they're dehydrated, and we're gonna do their normal replacement, but we're gonna replace some losses in that. So that's just some of the language you might hear. So some things that would cause us to have an increase of requirements of fluids, right? What things are gonna cause dehydration? Fever, vomiting, diarrhea, right? High output kidney failure, right? Diabetes insipidus, which comes up a little bit later. Diabetic ketoacidosis, that comes up in MP4, but that's very dehydrating. Burns, that's something if you haven't worked with burns yet, dehydration and fluid loss. In a burn with that exposed skin, we lose a lot of fluids. That is a big, big deal. They can go into hypovolemic shock just from losses from the burns. Generalized shock probably has a little bit to do with the burn there. Tachypnea, that insensible losses. If you're breathing really fast, you lose a lot of moisture that way. The radiant warmer, so the baby under the warmer, we're cooking them, right? We're gonna have fluid losses that way. Phototherapy, same things, a little bit warmer under the tanning bed. My daughter spent a few days under one of those, cutest pictures ever. And then post-op bowel surgery. Right, so decreased requirements. So this is where you're retaining a little bit more fluid, where we don't spend a lot of time in that area in pediatrics, but any kind of heart failure, syndrome of inappropriate antidiuretic hormone, mechanical ventilation, tend to have more fluid excess in that situation. And increased intracranial pressure. We don't want to put extra fluids on somebody who's got a lot on their brain already. So just some things to think about. So all of this is to try to maintain homeostasis and an acid-base balance, and that can be affected. So what type of loss they might be having could change how their acid-base balance is. And like I said, their infant and their kidneys, they're not able to compensate for these things, so they're going to have changes quick. So like I said, that's the infant. Older child can adjust more because now their kidneys are maturing and are able to help kind of compensate until then it can't anymore. We need to. So body surface area makes a difference. You know, we talked about that already. Skin is the root of fluid loss, right? So we can't forget about that. And then greater losses in that GI tract in sick infants. So we're losing electrolytes there too, so you can have like an isotonic loss with GI losses. So I've already mentioned kidneys are immature at birth and efficient at excreting waste. So they do it, but it's not in an efficient way. So when it's overcome by for whatever reason or lack of intake, it can really stress the kidneys. So they have difficulty diluting the urine, conserving those electrolytes, all of those things. So that relates to that fluid shifting that can occur real easily in infants. And because it can happen so quickly and it can be real devastating, it can be a critical situation. So we almost always hurt those fluids when any of these conditions occur. We want to make sure that at least we're pushing that P up. So that's another one of those priorities is, are we maintaining our hydration status with kids? Because it can happen quick. So we don't want to be chasing our tail, we want to be ahead of that game. So I mentioned sensible losses, fever too. If they got these high fevers, and we're giving them the Tylenol to get the fever down. One for their comfort, two because of the fluid losses that we get from it. And it's okay to let a fever go if the child is not really bothered by it. You know what I'm saying? Like I don't know if any of you have ever heard, well, just because they have a fever, it's really their body working on the illness and it's fighting it off. And that's true to an extent, but we still have to be making sure they're hydrated while that's happening too. If we're not going to give them Tylenol to treat the fever, it's totally fine. Have you seen any moms in here? Like they got 102 and they've been running around. I'd be like on my deathbed if I had 101. But at 2, it's like it's no big deal. They can tolerate them a lot easier than we can. But we have to be thinking about, all right, but they're going to hit a wall really quickly, especially if they're busy and they're not drinking and staying hydrated while they have that fever. Urinary loss, fecal loss, like diarrhea. All right. Okay, so here, just when you thought you were done with dosage count, I don't plan on putting one of these kind of things on a test. Because I don't have a little badge buddy for you that's to remember this. Although you will, it's really more important for when you're in practice, but know that we have this way to calculate their maintenance fluid. And this is a common thing in pediatrics. We have a daily maintenance. This is more math, more fun. I like math, I'm sorry. I'm a numbers person. And I think if you really like numbers, you'd really like pediatrics, you'd really like the ICU. We do a lot with numbers. We do a lot of weight conversion, weighing of diapers, eyes and O's, maintenance, weight-based dosing. All right, so what's happening here? We need a weight in kilos. Every pediatric patient that gets admitted or shows up in an emergency room, first thing you do is get a weight, right? Unless, of course, they're not breathing, you have to start CPR, right? We get a weight. Even then, we still need a weight. No, we'll do the Brazil tape and we'll give their medications out. But we need the weight to determine their medication and their fluid replacement, right? This is a medication too. So how we determine their maintenance fluid, right? Equal replacement, no deficit here. We're just talking about maintenance. So if they're sick and they're not going to be feeding, we want to keep kind of an even steady flow of their hydration. So we take their weight in kilograms and we do this calculation out, and it gets a little confusing because we're going to do 100 milligrams per kilo for that first 10 kilograms of their body weight. So let's see, what was my example? 29 kilos. Let's start with 29. All right, so the first 10 kilos of body weight. So we're going to do 100 milliliters, right, times the first 10. So that's 1,000. Just to start. We have 19 left to work with, okay? That's where it gets kind of confusing. Like, what do you mean the first 10, right? So now what do we have? We have 50 milliliters. For the second 10, we have another 10 left. Anybody seen this before? Is this brand new? There's a 4-2-1 rule, but I'm just going to show you this one for right now. So we have this, and now what do we have left? 9 left. Yeah, you guys ready? All right. So we've got 20 mils for the next, for what's remaining.
9.
Oops, what am I doing? 20.
Yeah.
20. I'm going too fast. Times 9 equals, right? So we have 1680 milliliters per day. A little over a liter and a half, right? For a 29 kilo. What's that in pounds? Can you reverse that? Kind of gives you an idea of the size. I don't know if you all can think in kilos yet. What is that?
60 something.
29 times 2.2. 63 pounds. To a child, but not an infant, right? It's about a little over a liter and a half in a 24-hour period. So then what we do, if we're doing continuous IV fluids, and that's how much we want to give in 24 hours, what do I do to that number? Divide by what? 24. Gives me, anybody do the math? 70 milliliters per hour is their IV maintenance rate. Right? Whatever IV fluids they prescribe, that's the rate for somebody who weighs 29 kilos. For maintenance. There's a 4-2-1 rule, which gives you the per hour. It's a little bit off in the numbers. This is a little bit more accurate, but this is what the residents or the providers are how they're gonna figure out what your fluid rate is. So you can double check that. You can be like, why are we giving 100 on this 8-year-old, milliliters an hour? Are we trying to rehydrate them? Let's figure out what their maintenance rate is. So there's a way to do this. This is the Holiday Seeger method. So we can do it in the 24-hour. We can take that, and then if we know we have replacement to do, we can do 1.5 times that maintenance. Remember I mentioned that before? Or we can do 2 times the maintenance to try to get some replacement fluids in. Sometimes we'll order a bolus. So they might try that, and then whatever's left over of the estimated loss, they'll throw in their IV fluids. Right? So then they take that and they'll divide it by 24 hours, and you get your hourly rate on your pump. Not so bad, right? So that's how we calculate the maintenance requirement. So we're dehydrated when our output exceeds our intake, right? We've got more outgoing one way or another. Vomit, diarrhea, not drinking, we're gonna have some dehydration occurring, right? Impaired oral intake, vomiting, diarrhea, insensible losses. Again, fever, tachypnea, think RSV baby. There's isotonic, hypotonic, hypertonic. We talked about that before, which leads to your isonatremic, hyponatremic, and hypernatremic. What is that? What is the natremia? Sodium. So in your isotonic dehydration, now we're talking about the tonicity in your extracellular fluid, so what's in your blood, right? So isotonic is the primary form of dehydration, equal losses, right? So you're gonna have normalized looking electrolytes, but you have less of both floating around. So you're not gonna have any shifting of any fluids between the cell and the extracellular fluid. Diuretics do it, excessive vomiting, urine loss. Now over time, these things might change, right? So initially, you're usually isotonic, more common type of dehydration. We can have this hypotonic, think of the hippo-inflated red cells, right? If we're hypotonic, that means lower solutes in the blood, which means that water's gonna shift into the cell. That's the end result, but you start out with that hypotonicity, right? So electrolyte deficit is greater, so that our losses of electrolytes are more than what our water. That sounds confusing, doesn't it? So we've lost more electrolytes, leaving dilute blood, not a lot of solutes. So serum sodium is low, so you know that from hypotonic, right? lower than your 130 or 135. So this isn't common in pediatrics, but if somebody's been sick and mom and dad's just given them like apple juice to try to rehydrate them, that is an isotonic fluid, or hypotonic, I'm sorry, I said hypotonic fluid. Not a lot of sodium in it, really more sugar than anything. It can cause them to be hyponatremic. So they want that electrolyte replacement like Pedialyte, right? Because of that sodium piece in there. Equal losses, you need to have that sodium replaced, or you're gonna end up hyponatremic or hypotonic. Okay, it looked very similar to the last slide. So in hypernatremic or hypertonic dehydration, we've lost more water, we're left with concentrated blood, right? There's lots of solute in there, extra sodium in the blood. So the blood wants that water, so it's gonna steal it from the cells, and those cells shrink up, right? That's what the end result of that is. It makes that water shift. So sodium is high in the blood initially, right? Before that shift occurs. And high fevers can do this. Diarrhea, I know you heard about that in isotonic dehydration, but this is the end result over time. You can read into this. Gastric suctioning, right? We're losing a lot of that water there. You're losing electrolytes too, but the nasogastric. When we decompress the stomach, right? Somebody who's been vomiting too much, we're vomiting for them if we do that, right? We want to compress the bowel, but we have this issue here, which is fine. We're gonna have to chase our tail with that and think about the IV fluids that we're gonna replace them with, right? So we have to be aware that we're having these losses if we're putting an NG tube to suction in somebody. We better be thinking about, okay, where's my IV order while we're doing that, okay? All right, degrees of dehydration. I know it says it's important. It's really just, we do have a degree. It's not so much that in the numbers, it's knowing that mild, moderate, and severe dehydration can affect what kind of treatment we do, right? So we have to determine how dehydrated are they. It's not an exact science. They can estimate what kind of losses that they've had and determine how much replacement they want for these kids. So it's this colors, all dependent on the individual's body composition of water and adipose tissue. Like I said, it's not exact. It's more like an estimate. Okay. The degrees are in the mild, moderate, and severe. So this is in your book, but it's, again, not a table to memorize, more of just to conceptualize here. Weight loss, mild, moderate, and severe. We can kind of look through which type of dehydration we're looking at here based on what's going on. We had a 5% weight loss or 3%. To remember the daily weights, that helps us to determine how severe some of our losses are. All right, so slight thirst, moderate, or intense. Mucous membranes, moist, dry, or parched. Tears present, decrease, and absent. That's a big one in peds. When they're crying, do you see tears? If we don't see tears, they're dehydrated. Especially toddlers, even with those crocodile tears. You should have a wet face, not going crazy. That's usually our comment. We see them and they're all snotty. Wow, they're really dehydrated. I mean, they're really hydrated when they're real snotty. We're like, oh yeah, don't need a lot of fluids there. That kid's fine. Because fluids are always on our brain when we're talking about peds and dehydration. Jugular veins, yeah. Not always as big of an assessment finding. It's really when they're crying we see them. But yes, you can have external jugular vein visibility or not even visible, even with pressure. So if they're crying and you're not seeing those veins popping out, then you know, okay, that's pretty bad. Cap refill. So if you don't have a lot of fluid in your vasculature, your cap refill is going to slow down too. Right? And then urine. How often are they peeing? So how many wet diapers? Remember I was saying my eyes went right to that diaper. I wonder when the last time it was that they changed it. I bet it hadn't. It was a while before that video. So, and then this table, same page in your book. This is in the Hockenberry. It's just showing you what isotonic water loss might look like when you're looking at your signs and symptoms in your assessment. Hypotonic and hypertonic. So either of those are bad. Usually we're in isotonic but you've got gray color. So that kiddo we saw in the video in the ER with that doctor, that army doctor, we've got some gray color. I think you saw some of what's going on in the labs there too. So we've got some severe dehydration with electrolyte imbalance. Plus we also have respiratory acidosis going on. All kinds of mess. So same in kids when it comes to their pulses and weak and thready pulses, or how fast the pulse is. The more dehydrated are, the more your heart's gonna wanna pump to circulate things. You don't have a lot in there, so it's gotta make what's there work harder. Sunken fontanelles, you guys already knew about that. I might have talked to you about that in the newborn assessment, maybe a little bit. Alright. So, good picture there. You can kind of see how the different dehydration works. So, obviously, physical assessment is important, but why? What is it helping us to do? I mean, we just came off of a slide that helps you with that, right? Why is it important, that physical assessment? Besides knowing, say again?
You can tell which type.
Which type? Yeah, it might clue you into a little bit about what might be going on, especially the history. So physical assessment, it also includes that history. And it also might help you with how severe that dehydration might be, right? Mucous membranes, yeah. You're seeing sunken eyes, that is late, right? Usually we're gonna see those tears start to disappear early, and then sticky mucous membranes, but then you start getting sunken fontanelles is a little bit later, a little bit more severe. So you can kind of tell, okay, they've been like this for a little while, right? So your assessment can kind of tell you how severe. It can help you lead towards which type of dehydration. Of course, your labs are gonna give you more information about what type of dehydration you have, or what kind of fluid replacement they might be ordering, right? So you're not ordering the fluids, but we're watching for that. So our IV fluids in pediatrics almost always have, they should have dextrose in it unless there's a contraindication for it, like diabetic ketoacidosis. They're always gonna have a little sugar in there. They're likely gonna have some kind of electrolyte, you're gonna have some percentage of saline, so there's gonna be some sodium in there. You're gonna have some potassium replacement. Remember, the most common type of loss in pediatrics is that isotonic. So you have electrolyte loss, you're gonna wanna replace them. So we're watching those labs to see how they trend after we've started some IV fluids. So what is their response? They usually perk up pretty quickly. A lot of times that bolus is all we need, and then the IV is just maintenance from there. We're just kind of maintaining their hydration where it's at, and we don't really need to do any more bolusing. Unless, of course, we have continued losses. So intake and output. We're watching for vomiting, elimination patterns. Are they peeing more often? Are they filling their diapers? We're starting to see those things perk up a little bit. Nice thing about pediatrics, I know everybody's like, it's so sad in peds, they get super sick. They get sick quick, yeah, but they get better quick too. And they usually do get better. It's not very often that it's a really sad story. But dehydration is one of those things that's gonna make them real sick quick. So, obviously your vital signs are gonna clue you in, just like in your adults in there, it's just gonna show differently in kids, right? Weight changes, skin breakdown, mucous membranes, emotional status. Kids will tell you, like, even though they don't talk to you very much if they're an infant, that's another thing I hear about people saying, but you can't ask them what they're feeling. But you can see it all over their face and how they're acting, right?
They're not gonna fake it.
They communicate a lot more than some adults do. You don't need English words or language to communicate. Okay, so our goal is correcting the imbalance. So that's something the provider's gonna estimate is what kind of losses they have. Our eyes and nose help with that. So we really need to be strict with our eyes and nose. Sometimes if it's not even ordered, I might still do it anyway. Because I'm like, I think this kid's gonna start showing some losses here. I'm like, let me keep track of what their eyes and nose are. So you can make that judgment call. We're gonna treat the underlying cause, because we wanna stop the loss if we can, right? Not just monitor it, keep track of it. We're gonna start, our goal is oral rehydration first. And we'll often do like this trial with it. We'll try PO fluids, that's that refusing oral fluid, 2 to 5 mils every 2 to 3 minutes. Again, usually it's like a teaspoon every 5 minutes. like in the ER setting, they might just just a little bit, sips at a time. Let's see if they can keep that down, and that's part of that trial. We'll do that with them, and if they vomit again, then we might go ahead and do an IV. So they're gonna try oral first. Sometimes like I said, all it takes is a bolus, they perk up, and we're gonna keep trying to, unless it's contraindicated, or if they just keep vomiting, we wanna do a little bowel rest or stomach gastro rest. So we'll NPO them, we'll just try to rehydrate them, get them feeling better again, and as soon as they are feeling better, we're gonna start introducing those clears, like Pedialyte, back again, until they're tolerating it, because that's the goal. The goal is to get them back on the oral hydration. So they'll try this oral rehydration first before they go to the IV. So there's a 50 ml per kilo for mild, or up to 100 milliliters per kilogram. Again, there's your weight base. We always gotta know their weight. How much do we feed them? How much do we hydrate them with? How much medication do we give them? And then there's, we might do that 30 to 90 mils per hour. That's more on like their IV fluids for severe. That's kind of just thrown in there with that. But 10 milliliters per kilo for each stool or vomit. So if we're trying to rehydrate and we think they're severe, we'll probably estimate like that 100 milliliters per kilo. So 290 on our 29 kilo kid is our replacement. We're gonna try to get that much in, and we might space it out over time until they get up to the 290, and then see how they are from there. If they vomit again, we're gonna add another 10 mil per kg, right, to that. And let's say, no, we got two liters, right? That's what I'm saying. 2 liters, we got 110. So we're gonna try to get all that replacement in, and then if they vomit again, we're gonna do some supplemental replacement from there. That's what that 10 milliliter per kilo is. So basically all you really need is 50 to 100 for mild to severe for fluid replacement per kilo. This is a little bit of what our best options are. Sometimes we want to go right to Gatorade. We have kids that drink that for sports, for electrolyte replacement. But when we're sick, it's not a good idea. There's a lot of sugar in it, and that sugar can make the diarrhea worse, and we have worsening losses of electrolytes. So let's stay away from the sports drinks for electrolyte replacement when our child is sick. The hospitals will keep Pedialyte, we keep that available. That's just, like we have formulas stocked, we'll have Pedialyte stocked. They have those freezer pops, which are really nice too. Gives them the electrolyte replacement in a much more fun way. Of course, you know, IV fluids. So real quickly on this, I wasn't gonna get too much into the types of fluids because pediatrics, we've typically gone to our standby, like our go-to every time has always been, what is it, D5 half normal saline with 20 K in a liter bag, right? And the latest research says that really doesn't help that much. We actually need more sodium. They end up becoming hypotonic over time if we keep doing that. It's not enough of the sodium. So even though we have an isotonic, we're looking at that normal saline, that's more of an isotonic. We're throwing a little dextrose and potassium in there, but we're finding we're getting behind in our sodium with them. We're watching their sodium drop. So we tend to do more D5 normal saline rather than the half normal for replacement, even in infants. Like so younger, 5-6 months old, we probably do D5 1/4 normal saline versus our full 0.9% normal saline. So we're increasing our sodium content on them. Now, lactated ringers is an IV of choice for gastric losses just because of some of the extra electrolytes that are in there. But usually with diarrhea and all that other, we're going to do the D5 normal with 20 K. But that's kind of our standby. So all that iso and hypo is kind of thrown out the window. We kind of default to that unless we need to do other replacement from there. All right, and I think we're pretty much wrapping up here. So this is just your reminder in there that those exist. That remember these from NP1. But in pediatrics specifically, we're not necessarily going that specific with them. We're just starting with our D5 normal. That's usually what they're going with now. And that's it. We're not thirsty. Right to the minute. I know y'all wish I could let you go early one of these days. so that's your content for your first exam. So you guys have for now, I'm gonna get that,